thank you very much, and great initial talks, Joanna and Rob. So I really think, we're talking about the largest of platforms, but I think in terms of the next frontier or the next areas where we have opportunities for improvement, it's how do you address these medium vessel occlusions. I think the Zoom 45 and 55 end up being very elegant, tools for addressing more distal clots that still have an opportunity for having very disabling deficits associated with them. Just some disclosures. I'd just like to give an overview of our area. Grand Rapids is kind of centered at the bottom west side of Michigan. We have a spoken hub type system with over 200 thrombectomy a year, and we cover the majority of the western and most of northern Michigan. Grand Rapids is known for great stroke care, and I always like to give a plug for Beer City, USA, and invite everyone to come out and visit us when the weather is more favorable in the spring or the summer. Happy to host you, especially as things become more normal over time and as we all get vaccinated. So, what's the clinical challenge of medium vessel occlusions? It really does account for about 25 to 40% of acute ischemic stroke patients. And I think there are some challenges that are differentiate between whether or not these are primary medium vessel occlusions or secondary related to non-target embolization or embolization to new territory. And I think strategically, opportunities to chase after clots that may embolize following a thrombectomy is important, particularly since we're striving for 2B, C, and 3 every time. And unfortunately, half of patients with medium vessel occlusions don't obtain excellent outcomes, and we need to continue to strive towards an area where no disability or a minimal disability is really the goal of all these procedures. I think Dr. Hickson kind of alluded to this as well. I think the more distal you go with a wire and a catheter using a retriever, even a small retriever, there is an increased risk of hemorrhage. So how do we address that need? And I think these catheters, which are very atraumatic and track quite well distally, do serve really well in this function. And I think there's challenging detection. Some of these patients don't get their initial scans picked up with very distal occlusions, or there may be a hesitancy to even offer or discuss whether or not these patients are candidates with interventionalists. And I think the more cases that we have and the better the evidence becomes for chasing after these lesions, the question, and the discussions will become more clear as to what the right thing to do is under many circumstances. In terms of procedural challenges, I think, distally, there are challenges related to vessel catheter size mismatch. Certainly, putting a 71 catheter into an M2, especially more distally, is not ideal. And there are diameter discrepancies across the spectrum of different catheters that we are using. Catheter length, particularly for some of these more complicated lesions, ends up being a challenge. 5 French Sophia, for example, is 125, and if you're using a 95 long sheath, you can run into trouble in terms of getting it distal where you need it. Vessel selection more distally is challenging, and in my videos, you see most of our patients are treated with moderate sedation. As patients are moving and as you are tracking more distally, the reliability of a very good roadmap is important for navigation purposes. So I think there becomes not so much a debate as to what is better in terms of general anesthesia or moderate sedation, but you need to have really good pictures to be able to target these more distal lesions accurately and to select the appropriate branches. And I think as we push further, the need for general anesthesia may become more appropriate and may be safer under certain circumstances, so you don't have patients having the discomfort and moving during the interventions. And this is actually probably one of my earliest cases with a Zoom 55, where I used LDP platform. I think it was actually TrackStar, and then was able to snake up the Zoom 55 without a wire into the proximal portion of the branch, aspirate. And this just coincidentally happened to have a very nice beveled appearance to it. So the beveled edge of the 55 catheter, fit really nice into there, and a nice single pass recanalization with a very quick thrombectomy and a very nice angiographic result. In terms of differentiating comparisons to the other 5 French or 4 French catheters out there, I do think the clot engagement area related to that TRX tip is more ideal and is better for the 55 and the Zoom 45 catheters. The length definitely ends up being an advantage. And I think particularly with some of the longer microcatheters that we're seeing, in the 160, 160 cm length, having the better tracking aspiration catheters to match those will be important. And I think it gives you a lot of opportunity to leave your options open if you do need to use a retriever in addition to trying to get your aspiration catheter out more distally. I think the length discrepancy, unfortunately 125 is not really quite long enough to address the majority of more distal things that you might be looking to care for in time. And again, just greater clot engagement area associated with the TRX tie tip. And these are compatible with the spectrum of catheters that come in the Zoom stroke solution. And just a few videos to highlight, actually one more. This is a more distal posterior circulation case where I was able to snake up the Zoom 55 and you can see the beveled catheter here in the basilar quite easily and aspiration only. And this for me is I'd say a more substantial paradigm shift. I've conventionally been a retriever user, and I've been, I'd say, definitely dabbling more with ADAPT with the solutions and opportunities that we have here, and see an opportunity, particularly when you can really get, as Dr. Fifi was mentioning, when you can get the platform more distal, you definitely have good control and definitely have great opportunities for success with first pass effect with less embolization. This happens to be a case where more recently, where I did have an embolus more distal and was able to chase it down with a 45. And even with some mild tortuosity, of course, you can see the movement artifact here. You're able to get the catheter out quite distally. It is a little bit uncomfortable, but the patient does pretty well, and you get a nice result. This is a case that actually I did yesterday. This patient had a carotid terminus occlusion, was able to recanalize the MCA quite quickly with the large distal platform and a 71 catheter, had an embolus into the distal ACA. And this is a great video just showing the 55 tracking distally. And this is over a track 21 catheter. They really made the initial turn from that ICA into A1 quite easily with good aspiration of the thrombus and a great ability to get to the surface of that clot. And I think the following case for me was the most impactful. This was a patient who initially had a distal M2 occlusion late in the evening that I said I would, that I said was a good candidate for thrombectomy. He did get TPA, and then do the angiogram, and I see the clot is way more distal than it was when I initially reviewed the CTA. I said, we're here, let's see what we can do, and let's see if we can open the vessel. And for me, this, really did change my practice and approach to this patient population. You can kind of see the thrombus in this area here, in magnified view down over here. I'm able to get a J wire out there. It takes that loop quite well, track 21 microcatheter. And then the Zoom 45, sails around that curve, takes the twist, and right up to the face of the clot with a nice single pass recanalization. That was probably one of my earliest and most successful distal thrombectomies, and I think was an eye opener for me as to what was possible and maybe a future direction for how we should be approaching this patient population as a whole. And I think, the question is, is the stroke solution the next generation of stroke treatment? I do think in my practice, the catheters have enhanced my approach to distal occlusions, and I'm increasing the frequency for which I would perform thrombectomies, particularly with patients who have disabling stroke scales with low cores, and feel very comfortable with this solution. And I think there certainly is a need for more evidence in attacking this area. However, we need elegant solutions to help us safely address it. And I think we're kind of moving in that right direction. And 45 and 55 really are useful there in conjunction with the entire platform to address address that need.